We're good to start, sir. Sir, we can start.
Hello, Venkat sir.
We're really stuck.
Can you hear me?
Yes,
Yeah.
sir. We can start.
We can start?
Yeah.
Yes.
Yeah, okay. Good evening, friends. Welcome to this Tuesday evening academic session from Department of Critical Care Medicine, Yashoda Group of Hospitals. We try to bring some topic of interest for all of you, which are happening topics or the topics for all of us wanted to know some curiosity. So we have seen some news across the globe, including this part of the Southeast Asian countries, that we see a uptick of viral infections. And to be very typical, it's not the season where we see. The season is more of a uh, post-monsoon, maybe winters. But this is an off season where we see a trend towards some respiratory illness and viral illness. And this is not uncommon. We do see on and off spurts of cases here and there, from H1N1 to H3N2 to bird flus to influenzas, RSVs, and COVID cases on and off. But intermediately, we see a trend towards a particular variant being picked up and all. So we thought this kind of the seasonal fluctuations, off-season fluctuations are not uncommon in many of our ICUs and hospitals which we come across. So we thought of actually bringing a generalized topic of what is this uptick which is happening? Is it really reflecting a seasonal pattern or off-seasonal pattern? Do this really need to be worried, or this is kind of a normal epidemiological issues? So when we discuss this topic of this viral uptake, we had none other than in our mind that we should have Dr. Ganga Ketkar sir, who have been our formal director for ICMR and also being a part of WHO expert committee in many occasions and been there with us in many occasions for these academic sessions and probably sharing his experience, wisdom, and epidemiological perspective of it. So, thank you, Ganga Khetkar sir, being here and accepting our invitation. It is our honor and pleasure to actually have you here. Thank you for accepting it, sir, and sharing your expert opinion with us.
Thank you.
So we will have Dr. Kaladhar, who is the senior consultant and HOD, Department of Critical Care Medicine from Yashoda Hospital, Malakpet. He actually had a discussion with me last week when we saw some upsurge of COVID cases in his ICU. So he will bring some cases like that, and then we will take some questions to Raman Ganga Kedkar sir over the next maybe 30 minutes to see how these viral uptick reflects. Over to you, Dr. Kaladhar.
Thank you, sir. Thank you very much, sir. Welcome, Dr. Gangaketkar, sir. Again, coming onto our platform, sharing your insights. So, I will be going through some of the cases. I prepared a brief PowerPoint presentation I made regarding the live cases that we dealt with in our ICU. So, some of the cases I will be orally discussing. So, to go through, I will start with the one such case where the severity was a bit more. So this patient is a 26-year-old. She's a primey with 26 weeks gestational age. So she conceived through IVF conception. So the history dated, if you look at the 10 days back, she had increased blood pressure. It was around 140/90. With her regular antenatal checkups, she was going to in the local place, it is called Nalgonda, the second tier city is nothing but a district. So she was visiting one local gynecologist. So with her routine checkup, she found to have the BP which was bit on the higher side. But when they did a complete urine examination, there was nothing much of a proteinuria and all. But they, because being more than 20 weeks, they suspected a possible preeclampsia is developing. One such thing, like one excluding thing is the proteinuria is not there. But anyway, they started her on labetalol 100 mg once daily. So later what happened is for about 2 days, she developed a fever, which was a bit low grade, and then developed slight throat pain, and then had a generalized body pains. This history is all for 2 days. So she went to that local hospital and was seeking the opinion of the gynecologist. So when they checked the complete blood picture, there was a platelet count which was trending down. So it was around 30,000 and all. And the leukopenia was there. So they suspected plausible viral and all, maybe the flu, H1N1 and COVID, everything, the severe acute respiratory illness possibilities there, being a pregnant, being high risk. They thought it's better to refer, and they referred this patient to us. So when she came, she was, of course, initially in the emergency, she was conscious and no issues from the sensorium point of view. But with tachycardia was there, 110 per minute, and BP was 120 by 70. So respiratory rate of 22 per minute, bit tachypnea, and saturations are lower side, not very much low, but 93% on room air. The temperature around 99 degree Fahrenheit. So when we auscultated the lungs, there were right zone Krebs were there. And then, of course, being pregnant, wanted to maintain a good saturation more than 95% because to avoid any fetal distress and all. She was started on oxygen support with nasal prongs to start with around 2 liters per minute. So with this, the oxygenation bit improved and fetal examination per abdomen, when we checked, the heart sounds were good, like there was no fetal kind of distress or bad bradycardia, anything. So, being pregnant, we put a shield on the abdomen because we wanted to see why there are right lower zone Krebs and there is pneumonia development. So, put a shield to protect the fetus against radiation on the abdomen and taken a X-ray on that day. So, this was the ABG on this oxygen 4 liters. This is actually once she came to here and then slowly escalating oxygen dose has to be given because the hypoxia was slowly was worsening. When we checked it after 4 liters nasal prongs oxygen, it is around 74, which amounts to about near to the PF ratios of around 190 to 100. So if you look at the X-ray here, there is a right lower zone consolidation predominantly, and there are some infiltrates on the left lower zone also. So to start with, this was the thing she had. And when we did investigations, if you look at the WBC count is on the lower side, that is around 3,290, leukopenic, less than 4,000, and platelets were here 40,000. And when we looked at the LFT, it was showing a picture of transaminitis. GPT is elevated around 3 times, 2.5 times more than that, and SGOT around 3 times more than the normal levels. And being she's having a pneumonia, I wanted to check the CRP, D-dimer, the regular, generally we check. So we checked the C-reactive protein was elevated around 53, D-dimer also a bit high. Being pregnant, generally we expect D-dimer to go up, being a physiological change, being a prothrombotic stage of the pregnancy. But yeah, 7,920 seems to be still very high. So with this background in mind, there is a community acquired pneumonia, leukopenia, and surprising the platelet count is a bit less. We suspected, of course, the coming from a bit rural background always to rule out the tropical fevers. So to start with, we sent this dengue, malaria, scrub typhus, all were negative. So renal function tests were the normal side. Creatinine is around 0.7, so urea is around 20 and all. So then when they came negative and there is a pneumonia, then we thought it is a possibility. Epidemiologically now there is a viral infection more and more, and we had seen previously like flu in the November, December of a previous year. We thought we'll send H1N1 and even along with that even here and there COVID infections, we sent COVID RT-PCR. So both came negative actually. So next day, slowly her respiratory distress worsened. So initially we started with HFNC support, which was on the eye flow and FiO2. She was kind of maintaining for about 6 hours with this HFNC. Then later, after that also, the hypoxia was worsening. The saturations were going down below 85 and all. Slowly, her tachypnea worsened. Initially, she was around respiratory rate of 25. So then it is 35, like that. It was going up, and ABG was showing hypoxia. The PO2 PF ratios around 160, 150, like that. We thought the workup breathing was on higher side. So it's better we intubate this patient. So we intubated this patient, and when we intubated and post-intubation, if you check, the X-ray was worsening definitely. Especially if you see the left side, the initial infiltrates, they happen to be more and more like a kind of consolidation picture. But when we checked, because initially the X-ray was a bit better and then later it worsened, we thought, is it possibility any pulmonary edema kind of picture, pulmonary congestion is also developing secondary to any cardiac issues. But when we checked 2D-co, it was showing normal, not much problem. But the LV function, everything was good. RV function was also good. But pro-BNP, when we checked, it is bit on the higher side. So the entity of generally what we discuss is heart failure with preserved ejection fraction, where we see this kind of picture in elderly diabetic hypertension. But pregnancies, yeah, still possibilities there, but definitely bit on the lesser side. But anyway, erring on the side of possibility, we have given fusamide, just 20 mg, only start dose. And then, of course, slowly our oxygenation improved and chest X-ray was clearing. And she needed around 3 days of ventilation. We even thought of course, if she worsens, may need prone ventilation. Meanwhile, we explained to the attendants that the fetus survival may be in jeopardy, and probably, if needed, the mother is the first priority, and then later, of course, if needed, induction also will be done. So, but we were probably predicting that she may go on to prone ventilation. But anyway, she improved. In this picture, then after day 4, we extubated initially to HFNC. Another 24 hours HFNC. Slowly we came down and then switched over to oxygen support. Now she is very good. This is a stay of around, I think, 9 days. Today is 9th day. We are planning to discharge tomorrow. Yesterday only we shifted her to the room. So in this patient, the possibility of started with viral pneumonia, and then probably there might be a heart failure with preserved ejection fraction with pulmonary edema kind of picture, or otherwise viral pneumonia somewhat got worsened. So, but anyway, we could not get the etiological agent as such. We even sent the ET cultures which came sterile. So, 2 other cases, I prepared only the PPT of the, but 2 other cases I will orally tell. So, another case is a 60-year-old female. She had a history of thyroidectomy for malignancy, papillary carcinoma, around 4 or 5 years back. And then she was tracheostomized initially because of the big, the thyroid and all, and it was some retrosternal extension. So they did a tracheostomy. It was there for 6 months, and then slowly, once she improved, they removed the tracheostomy. So this time, what happened is she had a 2 3 days of low-grade fever, sore throat. She was using the inhaler in on and off. Then she presented. She became more drowsy. Taken to a local hospital where she found to have hypoxia, and even CO2 was on the higher side, around 70, because of which she was having drowsiness, increasing drowsiness, and they intubated the patient and shifted to us. So when we did a CT scan, it was showing bilateral lower zone consolidations. This patient also surprisingly did not have much of elevation of WBC, but within, I think, 2 days, we could be able to wean her off the ventilator. And then once we weaned off, and she was maintaining very good oxygenation and even CO2 clearance, spontaneous breathing trial maintained very well. We could able to extubate the patient to NIV. So once we extubated, we could see there is a stridor. So once we have given some steroids and all, we thought probable this is tracheomalacia versus any the laryngeal injury, like the vocal cord palsy. So when we looked at nasopharyngoscopy, then we could find that there is a right vocal cord palsy was there. Probably, I think this pneumonia exacerbated the existing whatever the vocal cord palsy, and she landed up in this situation. Another patient is a background history of CKD. So he was getting dialyzed, maintenance hemodialysis thrice a week. Then he came with same again low-grade fever. He had loose stools. In this patient, there were loose stools, and then he presented with a bit of hypoxia. But this patient required around nasal pumps 2 liters, and we dialyzed. And there was not much. We did only X-ray, but it was mild infiltrates on the bilateral lower zones. Surprisingly, we even thought like COVID in these patients. These two patients, COVID did not come positive. So we thought like some other viral infections might be contributing to this respiratory illness. So this is what we dealt with, sir.
So I think Kaladhar has explained in I think his experience of the last few cases in his ICU. So it's time now. The whole idea is to actually take inputs from Ganga Ketkar sir. So sir, first of all, what is this kind of a pattern which we see on and off in this viral illness? Being a epidemiologist, being a very senior expert in this area, is it a common pattern that we see? You name it influenza, you name it SARS-CoV, now you name it COVID-19, or you name it MRSA, you name it other viral illnesses. We see some amount of surge in and off, on and off. So, what is your take? Is it a common pattern which we see, and whether it is a seasonal or whether it is a off-seasonal? We see on and off this. So, how is this nature of this viral illnesses, sir?
Now, there are certain things which we must remember. One thing is the so-called issue of seasonality is going to get impacted because of climate change. Now, if you actually see, we never expected monsoon at this point in time, but things
True.
are happening. And when
Yes.
such things happen, you will find there what we traditionally call a seasonality, as in months, between this to this month, that will be greatly lost. So essentially, we should be prepared to meet the shock that there will be times when perhaps you may have to use diagnostic agents to say now perhaps diagnostic test to be used to say that this has changed, the pattern has changed and this has started now. But the so-called seasonality you will not see as easily now with the climate change that is occurring.
Okay, and this kind of virus behavior or a pattern which we see, the variants, contagiousness, or sometimes we see H1N1 being predominant. Sometimes we respiratory syncytial virus comes. Sometimes we see the bird flu, H3N5 comes predominant. What is your experience with this kind of patterns, and what is their implications?
See, it all depends on who is most easily transmissible. That particular strain is going to survive and predominate the wave that may occur at any given point in time. Now, does this necessarily mean that that would be a true reflection of the potential of any particular strain? We have to remember what we are currently seeing is what is called as antigenic drift. In that, there are genetic changes that are occurring on surface proteins of these viruses gradually. And since they are occurring gradually, you'll find one particular variant or one particular virus will predominate because it depends on their ability to infect other individuals. That is something which would be a guiding principle in terms of who could predominate. And the second thing which we have to also understand is how long that virus continues to remain infectious. Once it infects an individual, if it remains infectious to others for a longer period of time, the likelihood that that particular virus will predominate will be always higher. And the predisposition to infect whom is a question which we will have to also think about. Let's look at RSV. You will find RSV will have a different kind of a pattern. So essentially, what it talks about is the factors that are important in transmission dynamics suddenly will rise up, and that entire thing of predomination will depend on the transmission dynamics per se. Now, can we be very confident that this will not get altered? In today's era, it will be. In today's era, when there is a globalization that is occurring, when there are so many people traveling from one part to another part of the world, you will find that a strain which was or a variant which was not there will be introduced very quickly. And then it is a competition between those, and the competition dynamics will also change with the introduction of new kind of a variant. So it's a complex situation. We'll have to live with it.
So, this kind of what will be the role of vaccinations in them? So, we all took influenza vaccine, we are taking annually, and also we are all using COVID vaccines, boosters being spoken about. So, how these vaccines will play a role when we have seen so many of antigens drift, and also you're saying surface proteins being changed?
Yeah, so far, whatever evidence that we have within the country, because not many sequences have been done so far within the country through INSACOG, what appears is you have JN.1. For JN.1, we know that the vaccines that we were receiving, they were protective to us earlier. Now the second question is, would the other strain, other variant that we see, that is N8, NB.1.8.1, now should we be worried about it? Perhaps not so far. That consultation has also gone in that you don't need to have a different vaccine to prevent that. Neither pharmaceutical companies have been, or vaccine manufacturers have been advised to produce vaccine using this particular variant per se. Now, what does it essentially mean? It essentially means the vaccines which are currently in use can be protective. But there are two aspects which we have to think about. When you want to protect an individual from a vaccine, for those who are younger ones, those who are not vulnerable, the issue does not become predominant, mainly because you will find that every infection that occurs is going to be mild. It is not going to lead to any adverse clinical outcome. The result is the infection itself will act as a vaccination. So the person will be protected to a larger extent. Not only that, there is a emerging sort of evidence that if somebody gets JN1 infection or repeated COVID in younger age groups, at least, we do not know sufficiently about elderly, the long COVID tends to get better. Uh, that was one concept, if you recall, during COVID, the classical peaks that we had seen. There was one concept that if you provide vaccine, long COVID tends to come down. So boosters and then subsequently giving one to prevent long COVID was also a possibility. Now, as of now, if you look at US scene, both Moderna and Pfizer, they have used this JN1 strain in vaccine. Currently, what is available with them is a vaccine based on JN.1. No, but when it comes to India, what do we have? We have a Omicron vaccine, that too mRNA vaccine. Now the question is, would you advocate vaccines to people at this current stage? So there are few issues that we must really think about. One issue is, in any case, this particular phenomena that we are seeing is antigenic drift. It has still not acquired virulence, that is in terms of hospitalization, immune evasion, and death per se. What is important is its transmission efficiency is almost 1.5 times higher compared to the earlier variants that have come. Now, if you look at who should be given vaccine, and when should they be given vaccine, The principle should be, if I am to give the vaccine, I should be able to predict when this wave of infection is going to occur. No, because you want to give it between two waves. No? Otherwise, what will happen is today you provide vaccine. The vaccine will take its own sweet time of at least 3 weeks' time to produce neutralizing antibody titers, sufficient to protect you. So if I start as we see now, when we know that in a month of April the infection was first reported in India, every lab tends to take its own time to confirm which variant you have, and then we come to know about it. There is another facet that we must remember, that if the virus is spreading at a higher transmission efficiency, that is 1.5 times higher, it means it impacts the R0 value. And what do we mean by R0 value? You will find in a house, within a day, if somebody brings infection, everybody will be infected because it has a high transmission efficiency. So wherever the person goes, the person will ensure that there is a transmission of this infection to others. Now, what is the implication in epidemiology for that? The implication is very simple. If there is a very high transmission efficiency, the peak will come faster and the decline will also occur faster, because it spreads so rapidly that in a given area everybody will get infected very quickly, and the downward numbers will also be seen then. Now, what does that have a relationship with vaccination? If I provide vaccines now, it is quite likely I am too late. So what do I do with that particular vaccine? But still, as a part of abundant precaution, all of us must advise to elderly, to those who have chronic morbidity, to healthcare workers, especially those who are in that vulnerable zone. They must take these vaccines regularly. And when I mean regularly, every year, one may have to think of taking it based on our earlier data as to when is it likely to come into a wave pattern during this particular year, and probably try to protect us. Second thing which we have to remember is, should I really worry about these vaccines even among elderly? Perhaps that risk is low. As long as people are made aware, even if they are elderly, even if they are having chronic morbidity, we have excellent drugs which are currently available. You could use Paxlovid, but the person has to come within first 5 days of becoming symptomatic. You could use injection remdesivir, that you have to give it only for 3 days time. So essentially, what does it tell you? Whatever the risk will come, the risk can be covered to a larger extent. But provision of vaccine, when it should be taken, is going to be a difficult decision. Then
So,
in
sir,
those
sir, please go ahead.
no, then in those cases, is there any good news? Because this actually is telling you that this has become completely endemic. It is unlikely to go. But there is a good news hidden in the same. And the good news is simple, that whatever mutations that are occurring, whichever new variants are emerging, all these variants belong to Omicron lineage itself. Now, what does that mean? Perhaps new variant which will have higher transmission efficiency is unlikely to emerge, because now we are almost 3 years after
Main peak
Omicron's
waves.
development. Yeah, Omicron's wave, no? Which essentially means if it is not moving from Omicron's group, perhaps we should expect Omicron, like Omicron's, let's say, sublineage species or the variant will again emerge. A new one may bother us to some extent, but we should not expect that severity, hospitalization and death rates will be impacted because of
So we mean to say that after the first influenza wave, which we have seen in 2009, where we have seen swine flu influenza, H1N1 being a really a pandemic. And then after that, on and off from 11, again 14, we used to see the seasonal, variations and surge of cases, and then it is getting down. So, as you said, it became an endemicity. The same thing what we are seeing on and off the one or two COVID cases every week or a month, or on and off seasonal flu. So, mean what will be your epidemiological prediction about different respiratory illnesses which will be going through? Will this pattern remain to be the same, or in future, as you're saying, once you get into some kind of plateau like Omicron infecting everyone, or some lineage in brain, the severity goes down, its importance goes down. See, as of now, we have not been so worried like what used to happen in H1N1 2009 time, or 2022 or 23 time. But on end of the other problem is few deaths or a few lethal or a severe infections also create a panic among all of us. So what is our take home? You may see one or two deaths from influenza, one or two deaths from COVID are not uncommon. We have seen throughout, but when it is been kind of magnified in any of the forums, and that creates a lot of apprehension in many. So, what is your take on that? Will this endemicity continue and we will see this kind of pattern? What will be the behavioral change from a clinician point of view?
See, it is unfortunate that you quoted first influenza. See, for influenza, there is a very difficult situation for us. Even if you have a vaccine, the strains that tend to come from northern hemisphere will cause influenza differently. I mean, in a different period. And then July onwards, you will see the one that comes from southern hemisphere, they will cause infections as such. Now, what does that mean? Whatever WHO decides, it decides for only one season. That is why if you actually see in 2018, we had missed S3N2. S3N2 was caused, but it was not part of the vaccine because
Yes,
we could not see there is an admixture that occurs from northern and southern hemisphere strains, and that creates a problem for us. Now, what does that essentially mean? We may have to develop strategies, added vaccination strategies, to try and ensure that everybody receives influenza vaccine as such. Whether it should be once or twice is a question that we will have to decide. Now, second thing which is also important is when it comes to COVID, would you require vaccine? Unfortunately, there is no data. No. See, basically now you will have to undertake a vaccine trial only in elderly population, to try elderly and with chronic morbidity, to try and see how much is the protection. And if you actually look at that JN1 data, you will find the protection comes to about 50%, which is pretty low. But it's something which we have to deliberate upon. Some of these trials will have to be undertaken. Only then it can be included into adult immunization. Because as it is, one thing which becomes apparent is the risk of death is low. Now, how low it is? As of now, if you look at US data, it is only about 0.04%, which per lakh population, which essentially is very, very low for us. When we think about competing organisms which tend to bother us a lot, where the death rates continue to be higher. So how much of importance should we be giving to it is something which we will have to think about.
so how you want to actually give some what is a message to all our clinicians who are today listening to you? How do they prepare themselves, and how do they actually take these kind of surges or viral behaviorals in future?
Hey, as I say always one thing, that no matter what, when a disease becomes endemic, you need to follow COVID appropriate behavior. You will have to use masks. You will have to use your hygienic principles, which we had tried to lay down during COVID period. And this not may not be rigorously followed by younger generation. But those with morbidity, Those with the age, they have to do that. There is no other way. And
Okay.
if you actually look at it, it's easy to follow, not very difficult to do. And when we did that in the COVID peak, if we could do that, I don't see any reason why it should not become part of lifestyle.
That's one. And in future, how these patterns will be and how, as a clinicians, we all need to be prepared for it.
Now, in future, to my mind, no, though I said that the lineage has not changed, so perhaps the good news could be that the next variant is also going to be from Omicron family. But the reality is, coronaviruses are notorious. They may sometime come back with a new virus which could be pandemic. So where is the solution? The solution lies only in production of pan-corona vaccine, a vaccine which prevents any coronavirus that exists in the world. Only then we will perhaps be better off. And there is research that is going on. We have to be optimistic that someday we will strike gold.
Kaladhar, you have actually presented 3 cases. All 3 of them are fortunately doing good. Any comments from you? What is your viral season in the last? Kaladhar, are you there?
Sir, are you able to hear me, sir?
Yeah, please.
Sir, Raman sir, what do you think, sir? Can genomic surveillance can help? Do you think in knowing these strains which are going to come up beforehand? Active genomic surveillance. Do you think that helps in any way?
No, there are two
Variants.
things. There are two sets of answers that I would give. Since this is endemic, but it has low risk of hospitalization and death. Now, on the kind of surveillance that we do, you will require a different kind of an approach. If you find that COVID is causing more hospitalization, the ones when you actually see in the clinical field, and deaths as well, then perhaps it should be followed by INSACOG investigation to find out whether the strain, the variant which is circulating, is it the same or a new variant that has come? Right. That is one thing which we will have to follow. So mortality-based or morbidity-based, hospitalization-based surveillance would be useful now. Now the numbers game perhaps is irrelevant because it doesn't make any sense. Infections will continue to occur. Now the second one you said, what was it that you said?
Genomic sequence.
Genomic surveillance, sir. Yeah, sir. Told. Like there
There
are
was
many
one more.
limitations and gaps in sharing the data, na, sir. Most of the times, most of the people they don't share their data, and even countries, I can say. So, do you think there are gaps also there, like the amount of
What I think the Kaladhar is trying to point out, if we see the early case series and you try to sequence their genomes, will we get any clue from them that they will be more infectious or they will be threat for us?
No. Now I remembered what he asked. No, I'm sorry to interrupt you.
yes,
But
yes.
he asked, can we use this data that comes from genomic sequences to
Yes, sir.
predict when and which kind of variant will emerge?
Yeah, the
So
drift or the shift.
for this, AI tools are being developed where sequences are being fed to try and predict what would be the new variant that will come. Now, are they foolproof as of now? No, it is too early to say whether they would be useful in at least such near future for that matter. But it is quite possible AI tools will be able to predict the composition, genetic composition of the virus, the variant that is likely to be expected based on the mutation rates. And therefore, that is a possibility which we can't rule out. And second thing you were saying, I'm sorry, I interrupted you, but can you
Whether
tell
we should do
me?
be genome sequencing in the new few cases, which
In any
I
cases, we
think
detect. Yeah.
No, not in all cases. No, it doesn't make any difference. See, that's a costlier test. It takes time to do genomic sequencing. What is also important for us to remember is if you, in a season, if it was due to JN1, you will find 70-80% of sequences are only JN1. Now, what is the utility of such a data? So
No, the
you should
first
go
few cases when you see a surge of
No, what I would say is first do COVID. If you find there is COVID, if it is increasing hospitalization, if it is increasing death rate, then you go back to INSACOG or do sequencing to find
okay,
out whether the variant is same or different.
okay. So you mean to say when you find a hospitalization severity being a different, then go for to see what is the variant or what is the mutation which caused this, and keep tracking of that and create probably some form of either vaccination or other awareness among them so that you contain it not to go beyond a certain threat.
Absolutely, absolutely.
Anything else, Kaladar?
Yeah, do you come across any regional models or like in epidemiology as such, where it is very successful in curtailing these infections? Because when we had COVID, we had every country had different models for the for the prevention or for the controlling of the infections. Do you think any successful, very good successful model in the world which can be replicated? If you think, suppose we are going to face these infections in the future, which can be replicated and can take policy measures according to that. So, which can like control the outbreaks of this area, severe acute respiratory, or whether it's COVID, whether it can be H1N1. Did you come across any very good model like that?
No, now we have negative information about certain interventions that we carried, which we should not do. No, it's like screening people who are international travelers doesn't make sense. Lockdowns, they're of no sense. But if you ask me a question, what should make sense? We don't have any such studies. But what we know is what does not work. No? So we are still in a process of learning. If you ask me, with the kind of globalization that has occurred, you will find respiratory infections by and large would not have good models to use for containing. No, because these are respiratory infections. But we will have to keep looking for what could come out as something which is a solution which we don't know today.
Yes, sir.
Okay.
So
Thank you,
regarding
sir.
infection controls, suppose if we get a patient, suppose is there in the ICU among other patients being having a pneumonia, and we get suppose a COVID positive. So obviously, because COVID is everyone's in mind, there will be panic. COVID has come. COVID has come. Everyone think my patient is besides that patient. My patient gets. So, but this was not the case with H1N1. Yeah, of course, we used to follow, but we used to keep these patients among sometimes other patients and all even deal with it. So do
The
you think any
apprehension.
strict precautions have to be followed?
It is just that people do not know so much about H1N1.
Yes, sir.
True.
They have seen scenes of death during Delta wave
COVID.
on TVs when it comes to COVID.
Correct.
So they are always scared of something which is seen. No? If you recall plague that occurred in Surat, it was just one or two scenes that they had seen and everybody panicked. No?
Yes.
We never looked at numbers, we never looked at anything. No, that is the way we react as human beings, as our psychological defense.
Correct. Yes.
Thank you, sir. Thank you for being with us on this occasion and enlightening all of us, sharing your wisdom and all those epidemiological point of view. I think we carry all those messages, and thank you for being a part of it. Thank you, Kaladar,
Thank you, sir.
for bringing those cases. I end the session. Thank you, Ganga Ketkar, sir, for being with us.
Thank you,
Thank
sir.
you.
Thank you. Good night. Yeah.
Thank you.